really, since we started using artificial intelligence, we are able to expedite the identification of large aneurysms and treat them in more expeditious fashion. And the first case will be really the presentation of a very complex patient with a complex aortic anatomy that actually had several other comorbidities. It's a 67-year-old gentleman who presented to the emergency department with evidence of hematuria. Of note, he didn't have any significant medical history except for hypertension and history of brain aneurysm that was treated in 2007. And after that, he was on a continuous follow-up. Interestingly, he didn't have any imaging of the chest or abdomen performed during the monitoring of his brain aneurysm. So in the emergency department, patient received a CT scan with intravenous contrast of the chest, abdomen, and pelvis. And that basically showed 3 separate pathology. Next slide, please. So CT scan identified that the patient had a right renal mass that most likely was consistent with renal carcinoma, which was a new diagnosis. In addition, it demonstrated a very interesting abdominal anatomy of abdominal aortic aneurysm being a 6.1 centimeter without evidence of rupture. In addition, there was bilateral iliac artery aneurysms, which basically were 6.7 and 4.3 centimeter in diameter, which by itself represents a pretty challenging a case for decision-making to repair this aortic and iliac artery aneurysms. In addition, there was a lesion in the lung that was suspicion for lung cancer. Essentially, complex patient that requires multiple decision-making points. But interestingly, because AI identified the aneurysm and patient had a mass in the kidney, it was apparent that the coordination of 3 different services will be required. And our team communicated with urology team to how to best treat this renal cell carcinoma as well as this large aneurysm. Next slide, please. In the coordination, we basically decided that it would be better if we repair this aortic aneurysm endovascularly. And that would allow for the fastest procedure to be performed on his right renal carcinoma, which per urologist needs to be done really within 4 weeks, ideally. Essentially, there was a timeline that we needed to maintain, as well as we needed to coordinate with other services if there's any need to evaluate the lung cancer. And the third point in this case is like the tumor was large and was involving, potentially was involving inferior vena cava, where we basically made a decision that after endovascular repair, if there is a need for vascular repair, joint procedure will be performed in the operating room. Endovascular repair was performed in 4 weeks, and aorta as well as iliac arteries were treated. The IVE device was used for the right iliac artery, and endovascular repair was performed of the abdominal aorta. Left iliac artery was then repaired in a stage approach also with IVE device. 2 weeks later, patient was actually discharged on postoperative day 2, and 2 weeks later underwent right renal, right nephrectomy with actually partial resection of the inferior vena cava that was repaired by us with a patch. He recovered well after this procedure, and within another 4 weeks underwent IB repair of the left common iliac artery. Next slide, please. On this patient, the technology clearly allowed us to coordinate the care with direct involvement of the services. It also expedited the care by minimizing the time to consultation and allowed us to directly schedule necessary CTA of the abdomen and pelvis to perform preoperative planning, since the original scan was just the contrast scan. And then schedule the repair within that timeline that I showed earlier. And 2 procedures were performed within literally 6 weeks window, which basically significantly better than our historical timeline.